Good afternoon and welcome to HIT Policy Update, a webinar tweet chat combo from healthsystemcio.com, sponsored by OnBase by Hyland. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I will be your moderator today. We are hosting a simultaneous tweet chat with our managing editor and director of social media, Kate Gamble. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can view the tweet chat in the media viewer panel on the right-hand side of your screen. Just so you see how we're going to spend our time today, first we're going to hear from Dr. John Halamka, CIO at Beth Israel Deaconess Medical Center. Then we're going to hear from our sponsor, represented by Lorna Green, Manager of Global Healthcare with OnBase by Hyland. And then we will have our Q&A. Just a reminder to go ahead and send your questions in as they occur to you in the Q&A box, and leave the default set to all panelists. We'll take those later in the program, but again, send them in as they occur to you. So without further delay, we're going to turn it over to our good friend, Dr. John Halamka. Thank you for joining us.
Well, thanks very much, Anthony. And what an amazing day for you guys to hold a webinar. Because here we had yesterday the quality payment rule finally hit, so giving us some MACRA and MIPS guidance for the future. And then this morning, the Senate released the secret GOP health bill, suggesting that maybe Medicaid funding is going to be reduced or will not grow as fast as it has, and that will have implications for IT. So lots of things to discuss today. So, Anthony, because you and I are such good friends, I know you were up last night till 3 a.m. reading the 1,058 pages of the proposed rule for Quality Payment Program Year 2, the MACRA and MIPS outpatient physician guidance of how Medicare will be funded to these guys over the 2018 timeframe. And I know there are many of your listeners who want me to try to summarize this. And so, again, 1,058 pages. The good news is, and I'll post it on my blog this afternoon, is there's a 28-page summary that came out from CMS. And let me just give you a couple of the highlights of the Quality Payment Program Year 2. It has to incorporate not only the feedback from this transitional year 2017 received thus far, but also, remember, 21st Century Cures was passed after the original QPP, so it has to take into account a variety of legislative and regulatory change as well as environmental change. And some of the things that I think are good about this proposed rule, I think we all know that in the meaningful use era, sometimes, especially with stage 2, it felt like we were trying to change too much too fast. And it's fine for the vendors to create new software, but then you have to change your workflow. You have to train your staff and clinicians how to use this new software, and it just takes a long time. And any EHR change, whatever it is hard. It reduces office productivity and causes anxiety. So a couple of things you'll see in the Quality Payment Program Year 2 proposals are that we're giving small practices especially a lot of leeway by suggesting some of these advancing care information provisions, the kind of meaningful use stage 3 successor, are actually not going to be enforced for small practices. That the percentage in the formula of reimbursement that would have been advancing care information will instead be the quality metrics. So it really gives these smaller practices a lot of latitude to figure out their own way forward. As well, and this is important, it gives everyone, and this is outpatient, we'll talk inpatient in a second, outpatient-wise, the capacity to use their 2014 edition Certified Electronic Health Record in 2018, as opposed to moving forward with the 2015 edition, that sort of meaningful use stuff. And why is that important? It turns out that a lot of our vendors haven't yet certified their products for this 2015 Meaningful Use Stage 3 edition. And so Athena, for example, hasn't yet certified its products for that new edition. It will very shortly, I'm sure, But just, again, think about the time frame. Here it is June, and if you were forced to get the vendor's release and upgrade and implement and train and deal with all that change so that you'd be ready for January 1, 2018, it would be a stretch even if you started tomorrow. So that's good. We now can keep the EHRs we already have in place and use them throughout the 2018 year. As well, there are a litany of hardship exemptions and potential delays that you, as you pick your own pace, can elect. And importantly, in the Quality Payment Program Year 2 proposals, it gives you until December 31 of the reporting year itself to decide on a hardship exemption. So again, folks, don't worry that if as you read the rule, you see what's coming down the pike, if you haven't already applied for an exemption, it's okay. You're going to have until December 31st of the reporting year to file such an exemption. So one of the things that are important, I think we know that if you're going to pay a doctor based on quality and outcomes, the doctors may say, but wait a minute. You know, John Halamka takes care of 86-year-olds with stroke and diabetes, whereas Anthony Guerra takes care of 18-year-olds with ankle sprains. You know, how can you just suggest that my quality is poor? My patients are sicker. So it incorporates the idea of extra bonus points in the scoring methodology for caring for complex patients. So that's good. As well, it will... There's a sort of kind of confusing concept that you guys should read about in the summary that I'll post about the virtual group. Suppose you're a two-doctor practice, and can a two-doctor practice really incorporate all this innovation and change and quality metrics? It's hard. But what if, without actually doing a formal merger and acquisition, you affiliate with a bunch of your community docs who work together to all triumph and create great quality scores or adopt technologies together? You create a virtual group. And so in effect, CMS has said, we'll grade you not on your practice, but on the performance of the virtual group you assemble. And that's also a good thing. So, Anthony, I know, there's just lots and lots in this particular proposed rule, but let me focus a bit on some of the IT topics that you'll find. And in the summary, this starts on page 13. And so what you'll see is, first, it will, as I say, allow you to use existing EHR software, give you some bonus points if you do upgrade, but you don't have to upgrade. It's going to give you more flexibility in e-prescribing and healthcare information exchange measures, because we know in each region, maybe your pharmacies aren't wired. Maybe you're being penalized because your local environment isn't friendly to e-prescribing or health information exchange. Maybe your local public health department doesn't have an immunization registry. And so, again, it's going to give you some flexibility on how you do public health and clinical data reporting and sharing, give you extra points if you do it, but not penalize you if for reasons beyond your control you can't. Now, we'll be talking in a few minutes about the $155 million eClinicalWorks Department of Justice settlement. Important in the Quality Payment Program proposed rule is, what if your EHR is decertified? What if something bad happens to the software? Will you, the physician, the clinician, be penalized? The answer is no. So there's actually a retroactive statement in the QPP that says, going back through full calendar year 2017, if your EHR was decertified, we will give you a full exception to all of this. So that's also good. And then, as I was saying, for smaller practices, the entire advancing care information performance category is eliminated. It's made optional, which gives you a whole lot of flexibility. And there are other exceptions, like if you work in an ambulatory surgical center, you do not have IT-specific requirements. If you are a physician who has limited patient contact, like you're a pathologist and you're your patients are already dead, or you're working on tissue. You know, you're not going to be asked to take blood pressures or something, right? There's lots of these exceptions, which I would call a nice cleanup of the lessons learned from the Meaningful Use Stage 1 and Stage 2 experience. So again, I'll post this summary for you this afternoon, but I think you could say it's taken a lot of lessons learned and incorporated them into delays, exemptions, and allow you to, in effect, define your own future and move at a pace your practice is comfortable with. So if that's the outpatient side, what about the inpatient side? So remember, in April of this year, the Inpatient Prospective Payment System, or IPPS, final rule was published, but it was, as sometimes happens, a final rule with comment period. You know, I've never quite figured that out, Anthony. You know, it's
right.
a final rule, but we want to listen to you anyway. Okay. And the comment period, it just wrapped up last week. And what can you say about that? Because I know several of the listeners asked me if I could comment on, will we, for hospitals, see the same kind of flexibility and delays? And too early to know because, right, CMS hasn't digested all those comments. But I hear that many, many organizations commented that they, in a hospital setting, would need the same kind of delays, exceptions, hardship exemptions, etc., as we see in the Quality Payment Program proposed rule. So I will bet we will actually see this idea of you can use your existing certified health record in a hospital in 2018, with the notion we'll have till 2019 to get to the 2015 certified edition. So that'll be good. And that there will probably also be reductions in reporting periods, delays that allow you exemptions. These things that I have just described are just, they're not a sign of laziness. It's just a sign of reality that we've got so many things going on, it's hard to do this work this fast, given that products are just now being certified and coming into the market. So we'll keep watching CMS for any final guidance that comes out of their comment period that ended last week, but I think we can suggest that 2018 may very well be a year where inpatient and outpatient flexibility is such that we can use this as a ramp-up year to get to 2019 when we'll really start seeing this quality payment program and the IPPS revisions take substantial effect. Now, as we think also about the next year to two, we need to keep in mind 21st century cures and all the things that 21st century cures suggested. And let's go through some of those. So 21st century cures was initially created to accelerate drug and device innovation and suggesting new ways in which we could more rapidly bring these products and services to market. But from an IT perspective, there are several things that you would say were important. So first, remember in the Obama administration we had the IT policy and the standards committees that helped us advise the federal government. Well, 21st Century Cures wraps those into a single committee, the Health Information Technology Advisory Committee, or HITAC. And on our agenda, you'll see HITAC is likely to be fully staffed and operational next month. So all those interviews for all the stakeholders that are going to be in HITAC will hopefully be announced in the next couple of weeks. We've already seen, for example, Paul Ryan announced that Patrick Soon-Shiong, who runs NantHealth and is the wealthiest man in California, was his nominee for this particular committee. Congress gets 3 slots, GAO gets a number of slots. So we're already starting to see who will be on this committee. So that's 21st Century Cures gives us new governance. There's also in 21st Century Cures a suggestion that interoperability is very important, that making sure we don't have information blocking, that we have application program interfaces that enable patients to get access to their data will all be requirements and something that the government should measure and report on. Now, isn't it interesting, Anthony, maybe you saw the news, that Apple has just announced this week that it wants to be the center of the digital health ecosystem. with the idea that your phone would be the secure container for all your medical records. And sure, we've got Health Kit, Care Kit, and Research Kit today, but things like structured laboratory data and structured medication and allergy data today in Health Kit, Care Kit, Research Kit, they're more like just blobs of text, or they don't have vocabularies enforced. So if don't know exactly what Apple's planning, but this plays right into this 21st Century Cures idea that every EHR should have an application program interface for consumer-driven apps to get at their entirety of healthcare data and download it to the consumer. So probably see out of 21st Century Cures more of that. There is still a commitment in 21st Century Cures to a certification process to make sure that our EHRs do adhere to standards and are interoperable, and empowers NIST to continue to make sure that those standards are robust and suitable for purpose. And I think inspired by 21st Century Cures and the idea of information blocking and certification, you might see the Department of Justice, as we saw with eClinicalWorks, enforcing the credibility of these vendors to deliver what they promise, and if they don't, to hold them accountable. So I only mentioned 21st Century Cures because although it's device and drug specific, it has so many things about information blocking and new committees and interoperability and oversight that is likely to be important over the course of the next year. Now, what about Affordable Care Act revisions? We saw the House bill, which at one point our president called mean. Well, what about the Senate bill? Has it gone from mean to nice? Well, it was just released a few hours ago, and if you have a chance to read it, what you'll see is it's very similar to the House bill in that it is going to reduce a lot of the federal subsidies, and Medicaid may very well have a fixed budget, and all the subsidies for expansion will be rolled back. It will offer a series of tax credits, and those tax credits, in theory, will be used by individuals to purchase health insurance. And maybe the one place that it becomes less mean is it suggests that for a number of lower-income folks, that there will potentially be some kind of additional subsidy given to them so that they can get the health insurance coverage they need. But at least what I was expecting was that the Senate bill would be substantially different from the House bill. And other than the low-income folks getting maybe a little bit more subsidy, it isn't that substantially different. So I have a feeling there'll be a lot of interesting debate before we get House and Senate coordinating committee to put together a bill that is going to get universal support. I am often asked about the January 1, 2018 clinical decision support rule that was part of the SGR fix, the Protecting Access to Medicare Act. And if you don't remember the details, buried in that act said every doctor by January 1, 2018 must consult a authoritative decision support system before ordering a test like a CT or an MRI or a PET scan. And then, once they get decision support that justifies that test, they must submit that piece of evidence, that decision support rule, as part of the bill, so that there is a record of why the test was ordered and why it was reasonable. Well, here's the challenge. January 1, 2018, just around the corner, none of us yet quite even know how you would even record a decision support rule in a bill. And not quite sure CMS would have the technology to even parse that data even if we submitted it somewhere as part of the bill. So again, I don't have inside information, but you think you can guess, because CMS hasn't issued guidance as to how this should be done, that it is very, very unlikely that we'll see the radiology clinical decision support requirement January 1, 2018 effective date go forward. It will happen, and I think it's very reasonable to have decision support around radiology test ordering, but I would guess at least a year of deferral on that, as we refine the standards and make sure there are products out there that can meet this need and that CMS could even receive the data that was sent. So if that's not enough, that we're getting inpatient and outpatient reimbursement changes, we're getting new kinds of government enforcement and oversight, and we're getting complete change in the way insurance is funded, well, what about the Department of Justice settlements with eClinicalWorks, and what about what we're hearing from Athena and this aggressive hedge fund, Elliott Management, and its investment in Athena? I just say this is important because let's look at our ecosystem of Cerner and Epic and Meditech and Athena and eClinicalWorks, the sort of big EHR vendors, and how is each of them going to get through the next couple of years. And what we see with ECW is the accusation of fraud and the $155 million fine, for which the CEO, the CMO, and the COO are personally responsible for $154 million of that fine. That is, it's not coming out of the company's bank account, it's coming out of their bank accounts. And that is an amazing judgment. I think it is precedent-setting. At least in my 30 years in policymaking, I have never seen an individual named for a $155 million personal fine. So I think this is going to have implications for our industry, especially because the whistleblower received a $30 million cash payment. And so a number of folks in our industry are saying, can you find $30 million of deficiencies in your EHR vendor? There may be more and more either whistleblowers, attorneys, individuals in the industry looking for these kinds of defects. So it's just going to result in a much greater awareness by the EHR vendors of regulatory compliance and ensuring when they have said their product does something, it really does something in production and not just in the testing lab where it was certified. So important to watch that ECW settlement and the tone it sets for our other EHR vendors. And what about Elliott Management? So Elliott Management has acquired 10% of Athena's stock, and Elliott Management is well known for, in its last 20 activities with companies, of changing senior management and potentially breaking up or selling the company. So, yeah, and I just think we should watch, because just as ECW is going to be slightly distracted with its regulatory and compliance issues, you could imagine that Athena might be a bit distracted as Elliott Management begins to demand some more accountability from senior management and potentially could be shopping the company around. And you do scratch your head and say, who would acquire Athena for $4 or $5 billion? It's probably not going to be Epic or Cerner or Meditech, so might it be some other third party? And hey, Anthony, I don't know if you saw the rumor, it was last week. It said Apple is going to buy Athena. Don't worry, fake news, not happening. But that's the kind of speculation that we're going to see. What about ONC's direction? So remember that Don Rucker, our new national coordinator, was a Beth Israel Deaconess emergency physician for a number of years. I know him very well. And Don has gone on record by saying ONC's major focus over the next couple of years will not be healthcare IT adoption. That was prior national coordinators. It will really be two things. It will be usability of the applications that we have and the interoperability for various purposes. So when you look at ONC's budget, which was cut by a third in the Trump administration budget proposals, that you'll see the bulk of the money on ensuring that the products and services coming out of EHR vendors aren't the enemy of clinicians, as they seem to be so often now, that they have enhanced usability features and that they are able to share data more liquidly than ever before, so that the patients can get the data, and provider-to-provider exchange is easier, and registry submission is easier. So that's likely what ONC will be focusing on. And finally on this slide, I already mentioned HITAC a bit, but the assumption I have is that the Health Information Technology Advisory Committee, as the replacement for the Policy and the Standards Committee, will take some of the 21st Century Cures mandates on information blocking and APIs and such, and then make recommendations as to how that may be put into regulation or legislation or sub-regulatory guidance. I guess the good thing about HITAC is that sometimes in the area of the Policy and the Standards Committee, the Policy Committee would say, here's a great idea, and it was a great idea. It just technologically, we weren't quite ready to execute on that idea. By creating one committee that has policymakers and technologists together, you may have a more agile approach and make proposals that are actionable given existing technology. So a couple of summary concepts. If you were to look as we head to 2018, what are going to be our big themes? I think this notion of moving from prescriptive meaningful use of check the box and did you have this feature or function to more of a focus on does the whole thing hang together? Does it support your workflow? Does it improve your efficiency? Does it support your team of care? That's going to be a huge focus. And maybe the EHR vendors, because they won't have, we hope, quite the deadlines they had in the past to churn out new product, will be able to focus a bit more on usability. And interoperability, I mean, this is, of course, a challenging term of art because I asked two senators, what is interoperability? And they said it's the exchange of every piece of data in the electronic health record with every stakeholder for every purpose in real time at no cost. And of course, if that's your definition of interoperability, we should all just pack up the tent and go home because we're not going to get there. But the idea of saying, can you, without huge cost or huge effort, get those minimal data elements you need to coordinate care when you need it, that I think we'll start seeing more of. And there'll be more products and services, a lot of them in the private sector, work by Commonwealth Alliance and EHR vendors and SureScripts and these sorts of folks to help accelerate interoperability and reduce the friction to data exchange. And I think a really important area to watch, especially given the 21st Century Cures notion of application program interfaces and the stuff we're hearing from Apple, the idea that they're going to be modular apps that sit on top of the transactional EHR systems to provide innovation and more usability and give each, say, niche use case some features and functions the EHR will never have. And the example I'll give you is, say, Alexa, ambient listing services, or Google has something similar, or Apple has just introduced something similar, where you would, say, be able in the home to interact with your clinician's office to schedule an appointment using voice, or while in the hospital, be able to get a nurse using voice. These kinds of modular add-ons will give us a much faster pace of innovation than waiting for major new releases from EHR vendors. So watch that. And I'm hearing more and more from the vendors about eagerness to support it. And then finally, and then I'll turn it over to Lorna, some innovations to watch. And I don't want to sound like I'm reading the Gartner hype curve here, but as I look to CIOs across the country, and I advise a lot of entrepreneurs, and I'm on both the East Coast and the West Coast frequently meeting with folks as they are implementing new innovation, some common themes come out. The word blockchain, I know, is very loaded, sounds like Bitcoin, ransomware, other things like that, but the idea of public ledgers where EHRs might, with appropriate security and privacy and consent, post information about your medical care to a public ledger where it is tamper-proof and cryptographically secured and enables the reconstruction of where you got care should we need to pull data from the heterogeneous EHRs that store your information today. This may be of potential use. Lots of folks investigating blockchain and public ledgers. Beacons, the idea that in a hospital or in a doctor's office you might have a Bluetooth low energy device, and as you approach that device, something happens. The fact that the doctor now knows you've entered the office means that they can be prepared for your visit. The fact that a doctor is walking into a hospital room and the medical record of the patient shows up on their iPhone. This idea of using hyper-local location awareness is probably going to be more important. I've already talked about Alexa and Google and Apple's various home voice services, and I think that will be the next interface after mobile. I know, again, machine learning sounds a bit like hype, but we found there are some really interesting so problem, Anthony, is I actually have an Alexa device sitting next to me and is now very confused. Machine learning services we found actually are helpful in mechanisms like figuring out if a paper-based document comes from an outpatient location. What is that document? What patient does it refer to? Where should it be inserted in the medical record? And helping clinicians navigate this morass of data we're collecting. And finally, we're also finding it's not only just text, but also images that can now, with this computer assistance, be analyzed, metadata encoded, and made more navigatable. So the themes on all these innovations actually tie back to usability and trying to make the patient's navigation of the healthcare system and the doctor's use of EHRs a bit easier. So lots of stuff today, but it really does all hang together. 21st Century Cures, QPP, IPPS, and all of this innovation may very well all be part of a same package, and I think you could see the trends. So the next year will be really one of the greatest times in IT. So don't ever be pessimistic. And let me turn it back to you, Anthony, and to Lorna.
Very good. Thank you, Dr. Halamka. Always entertaining and informative. And we look forward to the Q&A in a few moments. So now we're going to hear from Lorna Green, Global Healthcare Manager with OnBase by Hyland. Lorna, thanks so much for joining us today.
Thank you so much for having me. And you know, it's interesting as I started thinking about what did I want to talk about today. I know y'all don't want to hear commercials, so I thought about it. I want to talk more about what the philosophy of our company is, which really fits right in with what Dr. Halamka was talking about with all the innovations and things that are going on within our country. So I did want to start, you know, just telling you OnBase, that's our product. We are an information management platform. We manage paper, electronic documents, photos, DICOM images. We are not an EMR. We don't ever want to be considered an EMR. We are a complement to your Epic, Allscript, Meditech, Cerner systems, and that's what we are. But we are one platform where you can manage your data in one place for the outside data. And I thought it was kind of interesting that there at the end, Dr. Halamka, you spoke a little bit about, okay, paper comes in, where does this need to go in the EMR, in the ecosystem of electronic record? And that's what we do. But more importantly than just what we do is the philosophy of our company. Our company tries very hard to meet the needs of our customers in the ever-changing ecosystem of what's needed out there for your usability. And so every year we do an update, and it's now time for our OnBase 17. It's named after the year, and this year we have 3,500 enhancements coming into our product. Those are addressing things like you had mentioned, usability, interoperability, components of the OnBase solution that will help you meet your needs in your clinical workflows. And how we get those enhancements, of course, is there's lots of customer requests and ideas. Those come in through all different manners from our account managers and our development people. We send our teams out to observe how people are using OnBase, what we can do better, how can we increase the usability, decrease the clicks, all those type things that all of you are talking to your clinicians and your users of your software about. But one of the key components of how we determine what are the important drivers for where we're going with our software are our advisory boards. And over the last 4 years, we've put together, we started with a physician advisory board. These are physicians that are customer and non-customer physicians who have agreed to engage with us on our product. We also have a nursing advisory board that is staff nurses all the way up to VPs and chief nursing officers. And this year we formed a CIO advisory board. The because each of these users of software approach it from different needs and different vantage points. And the roles of these people on the different advisory boards are to give us real-world advice and insight, and then help us know where they're going, where your priorities are as a organization, so that we can make our software grow and to meet those needs. And our top things that we're looking at this year really line up with Dr. Halamka talking about the themes of usability. How can we make your clinician workflows more streamlined and increase patient safety, continuity of care, that type thing, bringing all the whole record together. Interoperability, that's always a topic of what we house, what we have, how do we share it out and get it to the other levels of care where it may be needed. And then, interestingly, we have started talking about modular and apps and where we're going to really support our users. So I just wanted to bring this to y'all to know that we really do value the voice of our customer. The philosophy of our company is to not just build software, but to be a partner with our customers. And I want to really encourage all of you, especially in light of what's gone on in our recent 6 months, with the EMR vendors. Stay engaged with your vendors. Tell them what you need. Push them on making sure that they're doing things at the highest level of credibility. And we at Hyland want you to hold us accountable in that way as well. And we ask you to please call, email, contact us if there's any way you would like to be involved in moving our product forward to meet the needs. Thank you, Anthony.
Very good. Well, thank you so much, Lorna. We appreciate your sponsorship and your messaging. So thank you. All right, we have some time for some Q&A, so go ahead and send them in the Q&A box in the right-hand side of your screen and leave the default set to all panelists. A little bit of a technical question, Dr. Halamka, that came in before our event. So let me run it by you, and let's see if you can drop any knowledge regarding this. This is from someone who works in a hospital. Even though I've been working hard to educate myself, I still have some confusion between MACRA. I understand MIPS and APMs and meaningful use, so the distinction between MACRA and meaningful use. I think this is because I work in multiple ECQM worlds, ambulatory reporting for CMS, payers, various incentive programs at the state level, CPC Plus, and so forth, which is causing me to doubt my understanding, specifically when folks throw around the term meaningful use as eligible hospital reporting guidelines. So could I ask you to provide a simple way to distinguish which term is applicable to whom and what the key differences are, please?
Sure. And so I'll be very honest that I don't know that at this point in history, there is really any one expert who understands the details of these 20,000 pages of regulations. And as you've mentioned, Anthony, it can be extraordinarily confusing to navigate. So here's the rubric that I use. The MACRA and MIPS legislation with its quality payment program has replaced the term meaningful use with advancing care information, and that is for ambulatory sites. So this is the physicians, the clinicians that fall under this QPP. And so yes, it's a fair thing to say. We don't really use the term meaningful use any longer when it comes to physicians, eligible professionals. We use the term advancing care information. Hospitals, however, at least at the moment, in the IPPS rule, still would use the term meaningful use. And, of course, we're no longer in a payment phase. We're in a penalty phase. And all the work that we're doing around the IPPS meaningful use requirements for Stage 3 are avoiding penalties. And so, if, especially like me, you work in an organization that has an ambulatory and inpatient and urgent care, the division between these two rules can get murky. And this is my hope, that over the course of the next couple of months, CMS will in its sub-regulatory guidance to IPPS, reduce the differences between these inpatient and outpatient rules to the point where the policies are going to be fairly similar about effective dates and how you will be measured and what certified software you have to use. So there you go. Don't use meaningful use as an outpatient, use it only in inpatient, but watch the next couple of months and maybe we'll see better alignment of these two rules.
Very good, very good. I'm sure that's very much appreciated. Next question, what do you think is the probability that CMS will switch to a 90-day reporting window for Stage 3 in 2018?
100%. Or maybe I should say 99.9%. How about that?
Okay.
And so when I said alignment of these rules, part of that alignment is figuring out how to defer January 1, 2018 effective dates, and probably the easiest way to do it would be by saying it's a 90-day reporting period for 2018, which would give us then an effective delay until October 1st of 2018 to begin a reporting period.
Very good. This is more of a comment from an attendee. Cures provides up to $1 million for each individual violation of information blocking as defined in the statute. A large EHR vendor found in violation for these business practices with deployment at national scale could face massive fines. Your thoughts?
Right, and so I was just in a seminar with a number of my clinicians, and somebody raised their hand and said, what is the fine if my vendor misbehaves? And I, of course, put my pinky in my lip and said, $1 million! And so, of course, this has a chilling effect because that's per incident, as you point out. And so it will lead to, I think, a better alignment of the products that are certified and the products in production. Because I don't doubt, I mean, the ECW settlement, and I realized looking at the comments, I may have said the word judgment. It was not a judgment. It was a settlement. The ECW settlement really illustrates the problem when you certify one set of software but put in production another set of software. The vendors will be increasingly sensitive to what is deployed in the field so they avoid this potential $1 million per incident fine.
Maybe you can enlighten me. What were the implications or the results for the certification body which had certified the ECW software, and any implications for the future for those bodies about their responsibility?
The answer is Drummond, who certified ECW, didn't do anything wrong, right? So that is, having personally been through the certification process for all the Beth Israel Deaconess self-developed products, the way certification works is you sit for days in Citrix or WebEx or GoToMeeting sessions showing certification professionals screen by screen what your product does. And the issue, I mean, yes, was there a piece of software that met certification criteria? Yes. The assertion here is that what was actually deployed in the field was different from what was certified.
Does that to you mean that the certification process has to change so it can't be fooled like it was?
So this is, maybe it's not the certifying lab that this is an issue for, because, right, they're just certifying against a checklist or rubric that the software does what it's supposed to do. There is, as you may know, this ONC oversight rule that came out at the tail end of the Obama administration that suggests that just as OIG, can parachute into your organization and do an investigation, that ONC or bounty hunters could parachute into your organization and determine if the EHR is performing as certified in your organization. And so I think this was ONC's answer to your question, which is we need someone to check, not the certification lab, but someone, a independent third party, to check to see that the products in the field really are functioning as certified.
Right, because then otherwise certification isn't really doing much.
Exactly.
Right, right. Talk a little bit about this, this radiology issue you were talking about getting into billing. Just when you mentioned that, especially in a best-of-breed environment, I wonder how many systems that might need to cross for that to happen, for the decision support to come up at the right time for the clinician, for that to perhaps get from a imaging system into the core EHR and then into the billing system. It sounds pretty daunting. And you mentioned a year. That even sounds like it might be short to get it all done.
This is a brilliant observation that you make, which is imagine.
Thank you.
But imagine that this is how, and I'll just play this through. Here's my workflow. Anthony comes to see me because his toenail hurts. I order a total body MRI. And I think one could without medical training, you would probably recognize a total body MRI for a toenail pain is probably inappropriate. So imagine that I'm in the middle of my EHR's ordering screen, and it says, oh, chief complaint, toenail pain. I have now gone out to a web service that is a third-party cloud-hosted decision support service provider and found that the appropriate imaging study for toenail pain is a toe X-ray. And then it shows you in your ordering screen, you know, these are the 2 or 3 choices you have. You know, it could be a toe X-ray, a toe CT, a toe ultrasound. I'm making this up. But certainly body MRI is not on the list. And then as you click on one of those choices, then there probably would have to be a pre-authorization that goes out to the payer to authorize that test, as well as the decision support rule being inserted in the bill. So your point is well taken. It crosses the EHR and CPOE, and it crosses conceivably the billing, as well as it may very well have a payer interaction component in real time. So lots of moving parts, which is what I think it's early to say this is going to go live, even in a year.
Right. All right, well, you know what? I think that's where we're going to wrap it today. We're about out of time. Again, a fantastic presentation, extremely valuable to the industry at the right time, which we seem to keep getting lucky, and news comes out right before these events. So when you close out your WebEx window, you're going to be taken to a post-event survey. Please take a moment to answer it if you would. Regarding continuing education, if you hold the CHIME CHCIO certification, attending our webinars gets you 1 CEU, so let CHIME know you were here, and if you've asked us to do so, we will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll get an email when this event has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox. And you can go to our website to view our upcoming schedule of events. So, and we do have one, coincidentally, we do have one coming up on blockchain, which I believe is on July 20th. So speaking of ledgers as being a future trend, attend our blockchain event to get the overview of what's going on with blockchain in healthcare. So with that, I want to thank Dr. Halamka, I want to thank Lorna Green, and I very much want to thank OnBase by Hyland for sponsoring. And I want to thank our attendees. So everybody have a wonderful day. Thank you.
Thank you.